Chronic bronchitis is a chronic inflammation of the bronchial mucosa due to irritants such as tobacco smoke. It occurs after the age of 40 years and is part of the syndrome of chronic obstructive pulmonary disease. There is progressive worsening with age, eventually resulting in chronic respiratory failure. It is aggravated by recurrent viral and bacterial infections. Oxygen therapy in these patients must be given with caution to prevent carbon dioxide retention due to depression of respiration. High flow rates remove the central hypoxic drive that maintains respiratory effort and can be harmful. The causes are cigarette smoking, industrial dust, chemical irritants, inhaled smoke from the use of biomass fuels like charcoal, wood. So the main symptoms are shortness of breath, particularly on exertion, wheeze, fever, cough with production of sputum for most of the year. Also infective exacerbation associated with increased quantity of thick purulent sputum. The main signs are barrel chest, pursed lip, breathing, clubbing cyanosis, increased respiratory rate, use of accessory muscles, that is the neck or abdominal muscles for breathing, and also hyperresonance on percussion and loss of cardiac dullness, wheeze or rhonchi, and reduced peak expiratory flow rate. Usually there are no signs too. Investigations are FBC, chest x-ray, sputum culture and gram stain, and also spirometry, shows reduced lung volumes, particularly FEV1, which is not reversed post bronchodilator administration. Treatment objectives are to minimize or stop cough, to prevent or minimize wheeze and shortness of breath, to reduce quantity of sputum produced, to prevent infective exacerbations. The non-pharmacological treatments are smoking cessation, physical exercise, good nutrition, and the use of face masks in high-risk occupations. Pharmacological treatments. For stable chronic bronchitis, you give salbutamol inhaled via PMDI in adults 100 micrograms, approximately 2 puffs, 4 to 6 hourly as required, and in children by nebulization 2.5 to 5 milligrams, 4 to 6 hourly as required, and then you give tropium inhaled using the dry powder inhaler in adults 18 micrograms, that's 2 puffs daily. And in children more than 12 years, we give 18 micrograms, 2 puffs daily, and less than 12 years is not recommended. And then you give a combination of fluticasone, salmeterol, inhaled via Acuhela or PMDI in adults 150 micrograms or 250 micrograms or 550 micrograms as 1 puff 12 hourly. And in children 4 to 12 years, give 150 micrograms 1 puff 12 hourly. Less than 4 years, safety is not established, so it's not usually recommended. You can give combination of budesonide formoterol. So budesonide formoterol inhaled via Acuhela or PMDI in adults 164.5 micrograms, 1 to 2 puffs 12 hours. In children more than 12 years, you give 164.5 micrograms, 1 to 2 puffs 12 hourly, but less than 12 years, the efficacy is not established, so it's not usually recommended. So for chronic bronchitis with infective exacerbation, give oxygen by nasal prongs 2 to 6 liters per minute, or face mask 4 to 8 liters per minute, or non-rebreather mask 10 to 15 liters per minute. And then you give salbutamol nebulized in adults 2.5 to 5 milligrams repeated initially after 15 to 30 minutes, then every 2 to 4 hours until improved. In children, 2.5 to 5 milligrams 4 to 6 hourly, and then you give ipratropium bromide nebulized in adults 500 micrograms 4 to 6 hourly until improved. And in children 6 to 12 years, you give 250 micrograms 4 to 6 hourly. And 1 to 5 years, you give 125 micrograms 4 to 6 hourly. The maximum dosage for children being 1 milligram per 24 hours. And also you give amoxicillin oral in adults 500 milligrams 8 hourly for 7 to 14 days. In children 6 to 12 years, you give 250 milligrams 8 hourly for 7 to 14 days. 1 to 5 years, you give 125 milligrams 8 hourly for 7 to 14 days. Less than a year, you give 62.5 milligrams 8 hourly for 7 to 14 days. Or you could also give erythromycin oral in adults 500 milligrams 6 hourly for 7 to 14 days. And in children 8 to 18 years, we give 250 to 500 milligrams 6 hourly 7 to 14 days. And 2 to 8 years, we give 250 milligrams 6 hourly 7 to 14 days. And 6 months to 2 years, we give 125 milligrams 6 hourly 7 to 14 days. You could also give azithromycin oral in adults 500 milligrams daily for 6 days. In children 10 milligrams per kilogram daily for 6 days. Or amoxicillin plus clavulanic acid oral in adults 1 gram 12 hourly for 7 to 10 days. In children more than 12 years, we give 500 125 tablets as a combined medication of amoxicillin and clavulanic acid 12 hourly for 7 to 10 days. And for 4 to 12 years, give 5 milliliters of 457 suspension 12 hourly for 7 to 10 days. 1 to 4 years, 5 milliliters of 228 suspension 12 hourly for 7 to 10 days. And 3 months to 1 year, you give 20 milligrams per kilogram of amoxicillin 12 hourly for 7 to 10 days. Less than 3 months, you give 50 milligrams per kilogram of amoxicillin 12 hourly for 7 to 10 days. And then you give prednisolone oral in adults 30 to 40 milligrams for 7 days. And then 20 milligrams daily for 5 days. 10 milligrams daily for 5 days, 5 milligrams daily for 5 days, until down over 2 to 3 weeks and stop. In children, 1 to 2 milligrams per kilogram for 3 to 5 days, until down over 2 to 3 weeks and then stop. And then you give acetylcysteine oral in adults 10 milliliters 8 hourly for 5 to 7 days. In children, give the pediatric formulation, that's 5 to 10 milliliters 8 hourly for 5 to 7 days. Or you could give carbocysteine oral. So that's in adults, you give 500 to 750 milligrams 6 to 8 hourly. And in children 2 to 5 years, give 62.5 to 125 milligrams 6 hourly. And less than 2 years is not recommended. So the referral criteria: refer all patients not improving on initial management with acute exacerbation, recurrent infection, or recurrent infective exacerbations or rapidly deteriorating, to a specialist.